All right. Congratulations for all the winners of the door prizes. As far as my introduction goes, like Marla said, I'm a pediatric pulmonologist and also board certified in sleep medicine. I'm a faculty in the Medical College of Wisconsin, working as a pediatric pulmonologist and also sleep specialist. And then I'm the medical director for the pediatric sleep program at Children's Hospital. So those are my credentials. I take this opportunity to thank the Wisconsin Sleep Society for inviting me for this presentation. This is my first presentation to the Wisconsin Sleep Society. I'm also glad that Marla and the board of directors felt that it is important to include pediatric topics. I'm very surprised to see two topics today. You already got a topic of presentation on children with Down syndrome and obstructive sleep apnea. So as you all know, sleep and sleep disorders in children are extremely common, and it is extremely important to know about pediatric sleep disorders. Having said that, how many of you in the audience are working in a pediatric sleep lab? Are you a pediatric nurse practitioner or a pediatric sleep tech? Anybody in the audience who are working in pediatric sleep? I see one person. Okay. All right. So otherwise, it may be a little bit more tough for you to understand certain concepts, but I will try my best to make you feel comfortable to know about pediatric obstructive sleep apnea in children. So I have no relevant financial relationship to disclose. However, we are talking about high flow nasal cannula. So as you know, when you are talking about high flow nasal cannula, I'm going to talk about the company that manufactures the device that will deliver high flow nasal cannula. That is going to be, company is a Fisher Paykel, and the device what we are going to mention is going to be a Airvo device. So what are my objectives for today's presentation? I'm going to review 4 topics. Number 1, explain to you how common is obstructive sleep apnea in children. That is what we call as the epidemiology of obstructive sleep apnea. Number 2 is identifying what are the causes for obstructive sleep apnea, and then identifying what are the treatment options for sleep apnea in children, what are the limitations of each and every aspect of treatment. And then we identify what is the role of high flow nasal cannula in the treatment of sleep apnea in children. And finally, we review the existing literature looking into the efficacy and safety of using high flow nasal cannula. So this is going to be in 2 parts. Part 1 is going to be to give you an overview of sleep apnea in children, because you need to know the fundamentals before you go and understand what is the high flow nasal cannula. So it is important to know sleep apnea occurs in all age groups in children. That is one thing that is a take-home message. Working in Children's Hospital, which is the most tertiary care referral center for the whole state of Wisconsin, we see newborn babies diagnosed with obstructive sleep apnea. Even they are diagnosed antenatally based on the syndromes. As you know, there are certain syndromes. For example, Peer-Robin syndrome, Stickler syndrome. They can be diagnosed antenatally by means of ultrasounds. They can identify a small jaw antenatal ultrasounds, and you are anticipating the baby being born with small jaw. The baby comes to NICU, baby starts obstructing and desaturating, and then they will call sleep specialist, they will call the craniofacial surgeon. So you can tell that we have babies who are few days old who are having obstructive sleep apnea. On the other end of the spectrum, we have a 21-year-old obese teenager with a severe obstructive sleep apnea. So there is no age limitation as far as prevalence of obstructive sleep apnea in pediatric age group. That is important to know. Having said that, sleep apnea tend to occur in 2 peaks. So first peak occurs between 4 to 6 years of age group. Second peak occurs during teenage years. So the reason it occurs between 4 to 6 years of age group is adenotonsillar tissue. So children do have adenoids, children do have tonsils. They are lymphoid tissue. They tend to grow along with the child, and they tend to become large in size. So the hypertrophy of the tonsils and hypertrophy of the adenoids tend to happen between 4 to 5 years. As you know, adenoids are located in the gateway to the airway. They are located in the back part of the nose, which is the nasopharynx. So if you have an enlargement of the adenoids, you are going to have nasal obstruction, nasopharyngeal obstruction. Then if you have a big tonsils, they are located in the pharynx, and you are going to have an obstruction at the pharyngeal level. So if you are obstructing at the pharyngeal level in the mouth and obstructing at the nasal level, so airway is nothing but nasal passages and mouth. So you have a complete obstruction of the airway. That is the reason children develop symptoms of snoring and symptoms of obstructive sleep apnea at the 4 to 6 years of age group, number one. Number two, teenage years. So the obesity is becoming more and more common in pediatric age groups. Obesity is a pandemic. All countries in the world, including low socioeconomic status countries, also they are seeing the increased prevalence of obesity in children. Corresponding with rise in obesity, there is a parallel rise in obstructive sleep apnea. As you all know this very well, as adult sleep practitioners, obesity is the most common cause for obstructive sleep apnea. Then compared to adult OSA, there is no sex difference. It occurs equally between girls and boys. And then it occurs in all races. We see Caucasians with obstructive sleep apnea, Asian boys with obstructive sleep apnea. However, it is more common in children with Afro-American population. It is more common in children with Hispanic children also. Having said that, it is extremely highly prevalent pediatric disease. So if you look at the first peak of OSA in children, that is happening between 4 to 6 years of age group, approximately 5% of children are diagnosed with obstructive sleep apnea. If you look at snoring, which is the most common symptom of sleep apnea, it occurs in 10% of children. If you look at sleep apnea, which is a diagnosis made by polysomnography, looking into apnea-hypopnea index of greater than 1, that's how we define obstructive sleep apnea based on PSG AHI criteria, the prevalence is up to 5%. Having said that, we talk about the obesity. Obesity is 50%. If you do polysomnographic studies, all children in Wisconsin, and then bring them all to the sleep lab, do sleep studies, 50 out of those 100 children will have sleep apnea. So it is such a common disease that I just want to emphasize that point there. And also, more importantly, as a pediatric practitioner, as a pediatrician, we see a lot of children with craniofacial syndromes. So we are going to talk about a little bit, there is a separate slide for it. So if you look at the airway, what are the components of the airway? There is a skeletal component, which include maxilla and mandible. There is a soft tissue component, which include tonsils and adenoids and pharyngeal tissue. And there is a neuromuscular component, which involve multiple hundreds and hundreds of muscles that control the upper airway patency. So if you look at who are the people who are high risk to develop obstructive sleep apnea, those children, when they have small maxilla or small mandible, they are very high risk for obstructive sleep apnea because of the skeletal involvement. So that is another component what we see in children, which you may not see in adult population unless a child is becoming an adult at 21-year-old. I'm sure Dr. Haley, when she talked about Down syndrome, our children with Down syndrome, they are living all the way up to mid-30s, late 40s, even 50s. And then you can see the sleep apnea being common around 21 years of age with obesity there. So as you all know, as sleep physicians and sleep practitioners, the diagnosis of sleep apnea in children is made by polysomnography. So then, like I said, it is pediatric, the causes for OSA in pediatrics is fairly complex. We call it as phenotype. I mean, if you remember your biology, what is a phenotype? We have a phenotype and genotype, right? Genotype means what are your chromosomes and all that stuff. Phenotype means looking at your physical appearance. So if you look at sleep apnea in children, there are 3 different phenotypes. Number 1 is adenotonsillar phenotype. Number 2 is craniofacial syndrome phenotype. Number 3 is obesity phenotype. These 3 phenotypes are so distinct, the way they manifest the symptoms, the way they present the complications, the treatment options are totally different among these 3 groups. So let us talk about each and every phenotype now very quickly. So talk about adenotonsillar phenotype. I explained to you adenotonsillar tissue, growth of tissue between 4 to 5 years of age. That is the first peak of prevalence of OSA in children. That is the commonest cause for obstructive sleep apnea in pediatrics is adenotonsillar hypertrophy. Having said that, there is a huge difference based on the severity of obstructive sleep apnea and the tonsillar size. What does it mean? You can see, you can examine a patient, he may have 4+ tonsil. If you bring them to the sleep lab, do a sleep study, it can be completely a normal study. You can see a kid with 1+ tonsil, he is snoring, you can bring them to the sleep lab, his study can be abnormal. So there is no direct relationship between tonsillar size and the prevalence of OSA and the severity of OSA. So these are certain facts about the adenotonsillar hypertrophy. And more importantly, you can do tonsillectomy and then you can cure the disease at the time when they are 5 years old. However, there is going to be a recurrence or re-emergence of sleep apnea due to other factors, which is going to be obesity as it becoming more and more common. We see this extremely common in pediatric patients. If you see a 15-year-old in my clinic, he is coming with snoring, and then we will take the history. He's already had tonsillectomy. You ask the parent, when did he have the tonsillectomy? Oh, when he's 5 years old. What is the reason why they did the tonsillectomy? Because he was snoring. What happened after tonsillectomy? Snoring has improved. And what happened then? In the last 3 years, he is snoring again. So that is the evolution of sleep apnea at 2 peaks and the progression of sleep apnea. So in spite of adenotonsillectomy, it is not a lifetime cure for OSA. You are curing the disease at that point of time based on the etiology. If there are other factors that are going to be put the patient at higher risk, it is going to emergent again at a later age group. So those are the reasons why it can occur as a second peak in teenage years. So this is, so the phenotype of adenotonsillar hypertrophy, the things what you need to know is common between 4 to 5 years. These are all otherwise normal children, non-obese normal children. Only symptom is snoring. You treat them, snoring will improve. The only symptom they have during the daytime may be attention problems, hyperactivity problems, ADHD symptoms. They don't have any daytime sleepiness. That is the phenotype of adenotonsillar hypertrophy. Now we switch gear and then go to obesity. So the obesity, as I told you already, it is becoming a pandemic across the world. So there is a marked increase in obesity between 6 to 11 years of age and 12 to 17 years of age, starting from 1980 to 2000. So the obesity prevalence doubled between 6 to 11 years and tripled among 12 to 17 years of age group. So back in 1990s, OSA is only present in 15% of obese patients. Now it is almost up to the 50%. So if you do polysomnographic studies, each study based on the study what you do, the prevalence ranges from anywhere 30 to 60%. And also there is a direct correlation between BMI and the apnea-hypopnea index. BMI meaning body mass index. Every one increment rise in the BMI increases the prevalence of OSA in that particular child by 12%. So if the BMI is 24 today, so his risk may be say 15%. If the BMI increases by 1 point in 6 months from now, it increases to 24%. So that is natural, right? Along with the reason why BMI is increasing because of the fat deposition. As you know, fat is deposited at several parts of the body. One of the most important area where the fat deposition takes place is going to be in the upper airway. If you do an MRI of the upper airway in children with obesity, there is increased amount of fat in the lingual, behind the retrolingual area. There is more amount of fat in the pharyngeal area. There is more amount of the fat in the subcutaneous areas of the neck, which is all part and parcel of the airway. So that is the important point. So when you look at obesity phenotype, they are different. They tend to have hypertension, number one. They tend to have hyperlipidemia, number two. They are already showing glucose intolerance. They have high hemoglobin A1C level. So you are talking about metabolic syndrome, obesity, and OSA as part of this phenotype, which is totally not seen in non-obese children. So the obesity increases the complexity of sleep apnea, and then you are adding metabolic syndrome. So these are the children who are high risk to develop cardiovascular complications, high risk to develop atherogenesis, high risk to develop cerebrovascular disease. So you are putting the seeds of cardiovascular disease, cerebrovascular disease at the teenage years. Unless obesity is treated, unless sleep apnea is treated, this is going to progress, and then they are going to develop adult diseases even as young adults between 13 to 15 years of age group. So, so that is the important part of this obesity phenotype, right? You are able to see these two differences. Then the third phenotype is syndromes. So these are all the syndromes what we see in pediatrics. This first patient is a Pierre-Robin syndrome. As you can see from the lateral profile, his mandible is extremely small. Oops, sorry. So the second patient is what we call as a Crouzon syndrome. You can see the flat bridge of the nose. They tend to have mid-face hypoplasia. Third patient is called as golden horse syndrome. Golden horse syndrome is manifested by involvement of the mandible. You can say Apert syndrome. Apert syndrome meaning there is craniosynostosis, meaning sagittal suture, coronal suture, lambdoid suture, they are all fused very prematurely. Consequently, the skull is abnormally located, and then your maxilla is completely deficient. There is no maxillary growth. So these are all the children we see in our practice. We have a huge genetics department in Children's Hospital. We see them at various ages. Newborn babies, we see 1-year-old with Crouzon's disease, we see a 7-year-old with Treacher-Collins syndrome. We get a lot of referrals for sleep studies from our craniofacial surgical department. They are the one who are going to treat the patient. So these patients are the most challenging patients to treat because they don't have a tonsillar hypertrophy. They don't have adenoidal hypertrophy. Adenotonsillectomy can't do anything. There is no reason to do adenotonsillectomy. There is no way you can put CPAP on these patients because already they have small maxilla. As we are going to talk about CPAP, what are the challenges in using CPAP in children, what type of masks you have, what type of interfaces you have. It is extremely challenging to do CPAP in less than 3-year-old and less than 4-year-old. Even in adults it is challenging, it becomes more challenging. So CPAP is not an effective treatment. So where you are left with, that's where we are talking about high flow nasal cannulas. We are looking for alternatives for treatments. So most effective treatment is going to be the surgery done by the craniofacial surgeon. For example, if you look at this first syndrome, these are the babies who are born, seen by the plastics. What do? They do is mandibular distraction. They take them to the operating room, they break the mandible, they put in a screws, they put in the plate, and they move the mandible forwards. And then they create a gap between the two halves of the mandible, and there is a bone growth that happens between the two halves. Then mandible comes forward, tongue is not falling backwards. You are going to treat your sleep apnea. So it is called as a mandibular distraction surgery. So the skeletal surgery is the most surgery, is the only way you can treat these patients. However, you can do mandibular surgery at any age, but maxilla you can't do until they are about 15, 16, or even some craniofacial surgeons, they don't want to touch maxilla until they are at least a minimum of 3 years of age, 13 years of age. So what do you mean? So they can't do surgery anymore, so they are left with sleep apnea. So this is the most challenging group of patients what we tend to see in our pediatric sleep medicine practice there. So these patients, they are totally, age groups are different, causes are different, treatment modalities are different, the tonsillectomy is not at all. So that is the complexity of OSA in children, so that I just want to give you some insights to understand them, the plethora of this. And then no talk on sleep apnea in children is complete without talking about Down syndrome. So if you come to my CPAP clinic, 50% of children you see are going to be Down syndrome. 50% of, another 30% are obese children, only 10% are non-obese, non-syndromic child who is coming and who is using CPAP. So I'm sure I don't want to talk more about Down syndrome. I'm sure you got a good talk this morning from Dr. Whaley about Down syndrome. So sleep disordered breathing is reported almost up to 50 to 80% of children with Down syndrome. So American Academy of Pediatrics have identified the prevalence of sleep apnea in children with Down syndrome. So there is a recommendation to do routine sleep studies by the time their child is reached 5 years of age. Every child should have polysomnogram so that you are not missing the diagnosis of obstructive sleep apnea. So the reason why children are higher risk for sleep apnea with Down syndrome, we know due to multiple reasons. They tend to have mid-phase hypoplasia, they tend to have macroglossia, they tend to have hypotonia, they tend to have adenotonsillar hypertrophy just like anybody else. Down syndrome children become obese by the time they reach teenage years. Obesity is so common in children with Down syndrome because their metabolism, they cannot be too active. So there is no burning of the calories by being more active, and then they tend to have more appetite. Some of the patients can have thyroid deficiency, as combinedly put them very high risk for obesity. So you are dealing with obesity plus multiple anatomic factors that predispose these patients for higher risk of obstructive sleep apnea there. So those are the three phenotypes. These are just three examples, and then we have patients with sickle cell disease with obstructive sleep apnea. We have patients with cleft palate. As you know, when you repair the cleft palate, you know what they do? They tighten the palate. They do what we call as a palatopharyngoplasty there. When you are doing the palate, what they do is they tighten the palate in such a way so there is no escape of the air or escape of the fluid through the nasal cavities. So however, you are creating a barrier in the posterior nasopharyngeal space. So immediately after cleft palate repair, you can see the child snoring and you develop OSA. So plastic surgeon has to go and then they kind of release the palatal surgery and then not making it too tight. So there are other conditions that we are seeing in children that put them at high risk for OSA that include sickle cell disease, cleft palate repair, syndromes like a mucopolysaccharidosis, achondroplasia, Prader-Willi syndrome. So these are very multiple medical disorders that are seen that are obstructive sleep apnea is associated with it. So why we need to talk about OSA in children? Because of the consequences. So what happens in obstructive sleep apnea? This is a nice mechanism. So what happens during the night time when child is having obstructive sleep apnea? So because of physiological alterations during sleep, it predisposes to development of certain cellular mechanisms within the body that lead to certain complications in patients. So this is same for both pediatric patients as well as adult patients. So what are the three things that happen in patients with obstructive sleep apnea? Number one is hypoxemia. We call it as intermittent hypoxemia. You desaturate, you recover, you desaturate, you recover. This is what we call as intermittent hypoxemia. Number two, hypoventilation. Particularly in pediatric patients, your CO2 level goes up, you become hypercarbic. So hypercarbia in conjunction with hypoxemia is more prone to end organ damage. And then finally, sleep fragmentation leading to daytime sleep. So these are the three physiological mechanisms. When you have these three physiological mechanisms or alterations in physiology due to upper airway obstruction, what happens within the cellular tissue? What happens in vivo? Number one, there is inflammation. Obstructive sleep apnea is nothing but inflammatory disease. What do you mean by that? If you do CRP, I don't know how many of you know CRP means C-reactive protein. C-reactive protein is a marker for inflammation. So CRP levels are very high in patients with obstructive sleep apnea. You do tonsillectomy, the CRP level goes down. So the inflammation is the most critical part of sleep apnea in children. Inflammation is the cause for atherogenesis. So it is a very complex physiology. Then there is increased sympathetic activity. The cause for hypertension in sleep apnea is due to heightened sympathetic activity. So that is another mechanism that happens. There is endothelial dysfunction. What is endothelium? It is the lining of the blood vessels. So there is alteration in the endothelial lining. So again, with thrombus formation, with the disruption of the endothelium, these are all complex physiological terms. Some of you may have difficulty in understanding, but these are well-known pathophysiological mechanisms that have been proposed to explain all the complications, explain the clinical symptoms of OSA in children. And we also talk about the metabolic dysfunction that include glucose intolerance, elevated hemoglobin A1C level, hypertriglyceridemia, more importantly seen in obese patients. So what are the complications of OSA in children? Most important thing is neurocognitive dysfunction. What does it mean is functioning during the day is affected in children with OSA. How does it manifest? In adults, it manifests as daytime sleepiness, whereas in children, daytime sleepiness is extremely uncommon. It is seen only in 10% of children with OSA. However, it is seen more commonly in obese children with OSA. That's a different story. So, non-obese children during the daytime, they don't develop daytime sleepiness, but they have inattention problems, hyperactivity problems, poor school performance. Some of them are diagnosed with ADHD. So, there is a huge amount of literature linking obstructive sleep apnea to ADHD symptoms. Number 2, cardiovascular dysfunction. So, they don't develop any congestive cardiac failure in pediatric age group unless you have Down syndrome, unless you have Prader-Willi syndrome, unless you have other syndromes. However, they develop what we call as a left ventricular thickness. Some of the patients may do develop hypertension, particularly in obese patients. Some patients may develop pulmonary hypertension if they have other complicating factors that include chronic lung disease, chronic cardiac disease, plus obstructive sleep apnea is a recipe for development of pulmonary hypertension. And then we talk about the metabolic syndrome leading to hyperinsulinemia, hyperlipidemia and all. So, the consequence of pediatric sleep apnea is involves all the multiple systems in the body. That's why we tend to propose a concept. Obstructive sleep apnea is not a simple upper airway disease, it is a systemic disease. What do you mean by systemic disease? Is it affects many organs in the body. So, that is an important thing. So, I gave you enough introduction about pediatric obstructive sleep apnea as part of part 1 of my presentation. Now, we are not talking about sleep study, how do you diagnose, that is not part of my focus today. So, we just quickly talk about what are the treatment options we have for treating OSA in children. So, we talk about 3 phenotypes, right. So, let us, because we have adenotonsillar phenotype is the most common. So, the treatment of choice for obstructive sleep apnea is going to be adenotonsillectomy. So, it is the first line of treatment for pediatric sleep apnea. Even in obese children, adenotonsillectomy is the first line of treatment. However, adenotonsillectomy is no 100% cure rate. There is increasing number of children who are going to exhibit persistent or residual obstructive sleep apnea even after adenotonsillectomy. Who are those patients who are higher risk for persistence of obstructive sleep apnea? Include those children with obesity, those children with craniofacial malformation, those children with syndromes, and then the severe the sleep apnea before tonsillectomy, the greater the likelihood that your sleep apnea may persist. What do you mean by that? If you have apnea hypopnea index of 50, you do tonsillectomy, it may not fall to 0. It may go from 50 to 20. It may go from 50 to 15. 15 is still severe sleep apnea. So, these are all the factors that predispose these patients for persistence of obstructive sleep apnea post adenotonsillectomy. So, if you look at this is a study that was published in looking into risk factors for adenotonsillectomy in pediatric patients. So, they have almost about 169 patients with adenotonsillectomy. You can look into what is the prevalence rate. It is almost up to the tune of 44%. So, they identify who are all the patients who are high risk for development of this persistence of sleep apnea include children with asthma, children with craniofacial abnormalities, children with obesity. So, this has been very well confirmed by means of the studies that are being performed in children. So, the take home message is tonsillectomy is the treatment of choice, but it does not lead to 100% cure rate based on underlying condition. Number 2, I'm sure that you are going to have a talk from of the dentist today. What we are seeing in more and more in pediatric patient is what we call as a maxillary deficiency. So, if you see a kid in the sleep clinic and then if you are examining the patient, sometimes you see 4+ tonsils and that's fine. Sometimes what you see is they have what we call as a maxillary restriction. So, they have a high arched palate, meaning a hard palate. You can see there is a vertical groove in the middle. It looks like an inverted V-shape appearance. So, it is very well known if the child starts snoring at 9 months of age, if the snoring is not treated, over a period of time, the snoring can lead to maxillary impairment of the growth of the maxilla, deficiency of the maxillary growth. When the maxilla is deficient in its growth, it causes obstruction in the nasopharynx, and then it can lead to obstructive sleep apnea. So there is a huge orthodontic component of obstructive sleep apnea, and then more and more orthodontics are involved in the practice of sleep medicine. What they are doing is what we call as a treatment, which is called as a rapid maxillary expansion. How many of you heard about the rapid maxillary expansion? Good, good. Yeah, I know you're the dentist. I saw you. You're going to give a presentation of tongue tie. So this is something very effective. Of course, how does it happen? So orthodontists see the patient, they will get the images, they do cone beam CT, look at the airway size, they put in an expander. There is an expansion phase which lasts for 6 months. There is a consolidation phase which goes on all the way up to 12 to 18 months, right now. And then the parent has to rotate this, and then it is only successful before the bones are fused completely. Because 2 halves of the maxilla, there is a fibrous ridge. So younger the patient, there is a more possibility of expansion. So if the kid is 15, 16 years of age, the expansion may be limited there. So it is important to know the rapid maxillary expansion as one of the treatment choices for pediatric obstructive sleep apnea there. And then there is a randomized, there is a meta-analysis that was performed in looking into how effective is rapid maxillary expansion. They have confirmed that there is improvement in apnea-hypopnea index and improvement in oxygen saturations were seen in children who are undergoing rapid maxillary expansion. So this particular study looked at 17 studies who have, these studies included almost 314 children who had the expansion done, and these children has been shown to resolution of obstructive sleep apnea, at least in the short term period, for about 3 years follow-up. So we talk about tonsillectomy, we talk about rapid maxillary expansion, then you go to this. So this is continuous positive airway pressure therapy, right? So this is the treatment of choice in adults with obstructive sleep apnea, whereas in pediatric patients, adenotonsillectomy is the first treatment option. We already talk about persistence of sleep apnea after adenotonsillectomy up to 20%, and also even up to the tune of 30 to 40%. So these are the patients who are going to be placed on CPAP therapy. So so this is the most common non-surgical treatment for pediatric sleep apnea. So what are the indications for CPAP therapy in children? Number 1, there is no tonsillar tissue. Then there is no need for tonsillectomy. Number 2, when tonsillectomy is contraindicated, if the patient has some platelet dysfunction, if the patient may have clotting disorders, so ENT surgeon is not going to touch the tonsils, so tonsillectomy is contraindicated. Number 3, we talk about the persistence of OSA after adenotonsillectomy. The severe OSA, higher the apnea-hypopnea index, greater the chance of persistence. Number 4, craniofacial abnormalities. I have shown you almost 7 syndromes where there is a craniofacial involvement. These are the patients also candidates for CPAP therapy. And then there are some patients who prefer to have a non-surgical approach for treatment. They are not in favor of adenotonsillectomy. So these are the groups of children where CPAP is a treatment of choice. We all know CPAP is very effective. What do you mean? We bring the kid to the sleep lab, you start the CPAP titration study, put him on CPAP of 4, you titrate it to 5, 5 to 6, and then by the time you reach the CPAP of 8, complete resolution of all apneas, hypopneas, normal oxygen saturation, no arousals. By the end of the night, your CPAP of 8 with apnea-hypopnea index of 0. We all know CPAP is highly successful and highly effective treatment there. However, in pediatric patients, it is challenging treatments. So knowing the challenges what we are facing, we do CPAP initiation totally different in children. Number 1, we don't do split night studies in children. We do a diagnostic study, we get the information, see the apnea-hypopnea index, confirm that this kid is a candidate for CPAP, bring them to the clinic, explain the sleep study findings, inform them the next step treatment is CPAP, and then we do fitting of the mask called as a mask fitting. We do get nasal mask, full face mask, nasal cannulas of different sizes. Our NIV technicians, they do the mask fitting in the clinic, and then child will go home with the mask. And then they go through a process called as acclimation. So they wear the mask 5 minutes in the morning, 5 minutes in the afternoon, 5 minutes during the evening time, increase the duration to 5 to 10 minutes, 10 to 15 minutes, so that child is getting acclimatized to the mask. There are some centers, they send the patient on CPAP, put them on CPAP of 4 before you do a split night study, and then get him accustomed to not only to the mask, but also to the pressure. Then you bring them to, then you make a phone call, and then you can download the adherence, whether he has been using successfully. If the child is not using CPAP at all, there is no point in using titration study. You bring the kid and then identify what is the reason for his poor tolerance of CPAP. How do you address this? Is it a mask issue? Is it a humidity issue? Is it a nasal obstruction issue? You address those issues rather than blindly using CPAP titration. And then once you do the CPAP titration, then we discharge these patients. So that is what we do in pediatric practice. That is uniformly across the country. That's how all pediatric sleep medicine. Unless you are dealing with an obese patient. I just have one patient before, apnea hypopnea index of 115. So I cannot go on doing the mask acclimation and so on. So we brought him to the clinic and put him on auto CPAP. He dropped his saturations multiple times. His saturations were less than 90% for almost up to 30% of the total sleep time. So those instances, we don't do titration, put them on auto CPAP, just like adults, what you do. However, otherwise, in majority of the children, we take due diligence, because the more education you do to the parents, the more you go through this process of acclimation, the chances of success of CPAP will be going to be better over long term. So, so this is, you can see by the slide, this in our CPAP program, how many patients we are able to see. You can see there is increasing number of patients that are being seen who are receiving CPAP therapy in our program, and then these numbers are increasing because of increase in the obesity program. We have a separate program for CPAP in our pediatric sleep. We have separate clinic for these patients. They come with the equipment. Clinic is staffed by a sleep physician plus an NIV specialist, and then we get the downloads before they come to the clinic. We review the downloads, we review the equipment, we review the mask, and then, so that is the process we go through. So, as you all know, it is not easy to adherence with CPAP. So CPAP adherence is extremely poor in children. So as you could see this slide, the adherence is only up to 51%. Overall adherence. So more than 50% of the patients are not able to adhere to the CPAP. How do you define adherence? You know this, right? Medicare guidelines, you need to use more than 4 hours for 70% of the time. So using that criteria, the adherence rate is extremely poor in children. I think these numbers are same in adults and also in children. However, children with developmental delay and then girls, they tend to tolerate CPAP better compared to other groups of children based on this particular study. So this is the challenge we are facing in our practice. So you have patients who need CPAP, and then there are patients who are able to use CPAP successfully. However, there are a majority of the patients who are not able to use CPAP, and where do you go from there? That is where we are. So we are seeing increasing number of patients dealing with this therapeutic dilemma. What is the next step in treatment for these patients? So just one slide on supplemental oxygen. So as you all know, oxygen is not treatment for OSA, because obstructive sleep apnea due to upper airway obstruction, you have to relieve the obstruction either surgically or CPAP therapy. The oxygen, supplemental oxygen, is you are treating the symptom, because hypoxemia is consequence of OSA. So you give supplemental oxygen and improve the oxygen saturations. So we see babies who are less than 12 months of age due to multiple syndromes. They are diagnosed with obstructive sleep apnea. Unfortunately, there are no other treatment options. They are not candidates for tracheostomy. They are not candidate for skeletal surgery. They are not candidate for CPAP. they are not candidate for adenotonsillectomy. So we do what we call as a supportive treatment or palliative treatment with supplemental oxygen, and then they go home on oxygen as part of treatment. And then there are some literature studies looking into when you are delivering oxygen through the nasal cannula, the flow itself can trigger the receptors in the upper airway, and then those receptors can maintain the upper airway patency by receptor mediated mechanisms. So that is a hypothesis that have been proposed. So it is important to know that oxygen can be a supportive treatment for certain group of children where you cannot treat them by any other means. So that is the part 2 of my presentation, where I have gone through various treatment options for obstructive sleep apnea, and each and every treatment: tonsillectomy 30% recurrence rate, CPAP 50% poor adherence rate, and then maxillary deficiency. It is only available as a treatment option if you have a maxillary restriction, supplemental oxygen. So after looking into all the treatment options, we are seeing increasing number of patients who are looking for other types of treatments. So the most common group of children who are looking into other aspects of treatment are children with Down syndrome, not able to tolerate CPAP, and obese children who are not able to. These are the 2 groups of children. So what we have in our program is we have a separate clinic for them. We call it as an alternative CPAP clinic. So these patients are seen in the clinic. I do the clinic with one of the ENT physician, and then we review the information. And most often these patients, they go drug-induced sleep endoscopy. It is also called as a DICE. They do ENT, they do scope, and they look into the nasopharynx, oropharynx, hypopharynx, look into the tongue. Where is the obstruction? Nasopharyngeal level, oropharyngeal level, base of the tongue obstruction. And then based on what are the findings in the DICE, they can do what we call as a base of tongue lingual tonsillectomy, they can do pharyngoplasty, they can do turbinate reduction surgery. So these are all the additional surgical treatment options that are being considered for these patients. And then some of these patients are great candidate for high flow nasal cannula. So how many of you are familiar with this high flow thing, or is it the first time you are hearing about it? Okay. So if you are working in an intensive care unit, either on the adult side or on the pediatric side, high flow nasal cannulas are used left and right. They are used in the emergency room, they are used in the neonatal intensive care unit, they are used in pediatric intensive care units, they are used in a general pediatric floor, because the high flow as a therapeutic treatment option has exploded in the last 10 years. So this is a very popular mode of non-invasive support. So this is being used in the hospital now for conditions that include acute bronchiolitis for respiratory failure, acute bronchiolitis with respiratory distress, acute hypoxemic respiratory failure, acute on chronic respiratory failure. So these are all the indications for high flow treatment. By doing high flow treatment, you are avoiding intubation. That is the primary goal of high flow. So what is high flow? High flow, the abbreviation for high flow, because high flow meaning you are delivering gas at a higher flow in liters, it is delivered through the nasal cannula. So the abbreviation that has been used to describe the treatment is called as a high flow nasal cannula. So that is the title of my presentation. So what does it do? So you have a system, you have a equipment that delivers the high flow. So the device takes the gas, heats up the gas up to body temperature of 37 degrees, and then provided almost 100% humidity, and then you can deliver room air, you can deliver 40% oxygen, you can even deliver 100% oxygen, and then the flow can go up to 60 liters per minute. How many of you are RTs here in this audience? You know, when you are doing nasal cannula oxygen, you do 1 liter per minute, 2 liters per minute, up to 5 liters. If somebody is needing more than 5 liters, you put them on the mask. And then if somebody is needing it, you put them on non-rebreathing mask. And then the maximum flow you can give through non-rebreathing mask is up to 15 liters. Whereas high flow, you can give up to 4 times non-rebreathing mask up to 60 liters per minute. So when you are doing high humidity, heated humidity, high flow, what happens is there is the inspiratory demand is going to be less. There is improvement in the functional residual capacity. There is improvement in there is a washout of the pharyngeal dead space. There is improvement in oxygen dilution. So this is a mnemonic you can remember for high flow. H stands for heated and humidified. I stands for decreasing the inspiratory demand. F stands for increasing the functional residual capacity. L stands for lighter because it is lighter than the ventilator. O stands for effective oxygenation, and then W stands for washout of the pharyngeal dead space so that you are not allowing to retain the CO2. So these are all the physiological mechanisms how do high flow works. So high flow is very successful in a hospitalized setting, which was established for more than a decade now. However, we are doing my talk today is how can you use high flow for patients with obstructive sleep apnea. So this is a slide that will explain to you, looking into physiologically, when you put patient on high flow for a patient with obstructive sleep apnea, if you look at the top part of the tracing here, you have the flow in liters. If you look at the bottom part of the tracing, that is the supraglottic pressure. So you have a catheter in the supraglottic area. You are able to measure the pressure. You also measure the flow. And then the TNI means a transnasal inflation. So we are delivering high flow air nasally through the nasal cannula. Instead of calling it high flow nasal cannula, this is an experimental study that was done in the sleep laboratory on a select group of patients. So you can see when he is not getting the high flow nasal cannula, you can see the pattern of the breathing. When you put the patient on high flow nasal cannula, which is the right side portion of the study, these are the physiological changes what you can see. What are those changes? Changes number one, there is an increase in the end expiratory supraglottic pressure. Number two, there is increase in the mean inspiratory airflow. Number three, there is a decrease in the supraglottic pressure swings. Number four is the supraglottic pressure threshold is decreasing the inspiratory flow limitation. And you look at the breaths, they are more normal contour breaths rather than obstructed breaths. So this is a physiology experiment that was done explaining the physiological mechanism, how do high flow works in patients. So then you go and then do a polysomnographic study. This is what you are going to see. On the top portion, you have a diagnostic study. All of you can know, you can see the patient is having multiple obstructive apneas. So you have certain tracings in non-REM sleep and tracings in REM sleep. Top portion is diagnostic study. The bottom portion being on high flow nasal cannula. You can see complete resolution of apneas, complete resolution of hypopneas, and there is improvement in oxygen saturation. So what you are seeing physiologically are able to translate into improvement in the PSG indices, which include apnea hypopnea index, oxygen desaturation index, improvement in oxygen saturation, and so on and so forth. Having said that, there are some safety concerns about using high flow nasal cannula. So when it is used in hospitalized setting, there are concerns about barotrauma, there are concerns about pneumothorax, there are concerns about air leaks. However, those are more common in patients who have obstructive lung disease, either COPD patients or patients with lower airway obstruction, for example, bronchiolitis. So, however, when you are doing high flow in OSA patients, it is extremely rare for that complication because they don't have any hyperinflation of the lung. They don't have any obstructive lung disease. They have upper airway obstruction. So those complications are minimal. Number two is infection. Many of you know Vapotherm, that is used to be one of the high flow device that was in practice about 10 years back. And then when Vapotherm device was being used in hospitals, then there was an infection that complicated all patients who are receiving Vapotherm high flow therapy because of gram-negative bacteria. So the company has to completely pull out all the equipment, and now they are able to correct the infection problem, and they are able to get new equipment now. So that was a complication that was reported in the past on using high flow nasal cannula. So that is not going to be concerned at this point of time. So then this is an example of 5 patients with a diagnosis of obstructive sleep apnea. So you are able to see 1, 2, 3, 4, 6 patients. So you can see the improvement of apnea hypopnea index and then improvement in oxygen saturation with so this is patient 1, patient 2, patient 3, and 4 and 5. So this is without treatment. You can see this patient apnea hypopnea index is 7. This patient apnea hypopnea index is 50. So after treatment, all of them have significant improvement, although sometimes it may not reach 0. So there is a decrease by more than 2/3. Looking at oxygen saturations, so this patient is very hypoxic with 45%. It increases all the way up to 90%. So these are all the case studies that were done looking into improvement of OSA following initiation of high flow nasal cannula therapy. So this is a meta-analysis. So this is a publication that was published very recently, looking at all the studies that were done using high flow nasal cannula. There are a total of 6 studies. It is also important to know these studies, they include only patients, small number of patients, 5 patients, 7 patients, 10 patients, like that. So they are done not only in the United States, they are also done in other countries in Europe. So if you look at sample size, where is my cursor there? So these are 10 patients here, there are 22 patients, there are 8 patients. So and then you can look into the flow rate that were used for these patients as part of titration polysomnogram. So they are able to use 5 liters all the way up to 20 liters. So most of these patients, they have underlying syndromes and they have craniofacial abnormalities. These are the groups of patients. They have been shown to be high flow nasal cannula has been extremely successful. So we have limited number of studies that are performed in children using high flow nasal cannulas, showing the efficacy and safety of using high flow nasal cannula for this particular treatment there. So what is the device that is available for delivering high flow nasal cannula? So this is a device that is manufactured by Fisher-Paykel as part of conflict of interest. I'm not promoting this product. That is the equipment that is being used currently in practice. So it is a humidifier with integrated flow generator. It delivers flow all the way up to 60 liters per minute. We talk about the warm and humidified respiratory gases. So the liters flow is there. So there is 2 airwoes, airwo and airwo 2. Airwo is only indicated for patients for hospital use. They are used on the inpatient side, and they are also used in the intensive care units. Some of the hospitals, they have about 10 to 15 airway units. They are using in the emergency room. As soon as a patient with COPD comes in, if he is having increased work of breathing, immediately they put him on airway, put him on 20 liters per minute, put him on 50% oxygen. Otherwise, he may need intubation, and then he may need to go to ICU with intubated. Whereas airway 2 is only currently the airway 2 is not approved for pediatric use. That is an important thing. In fact, CPAP is also not approved for children less than 30 kgs. So when we are using CPAP, we are all using off-label in pediatrics. So this is being approved only for hospital use. It is also approved for long-term facility use in a palliative care mode. Otherwise, there is no approval from FDA for airway use. That is the challenges where we are facing to use airway or using high flow nasal cannula therapy. These devices are not approved devices. That's why there is insurance denials. We have already have patients lined up for great candidates for airway. We just sent in prescriptions to DMEs. Nobody is accepting the prescriptions. They say denied, they say denied. So pediatric centers across the country are fighting these things, and they are able to talk to Medicaid, and then they are able to negotiate with Medicaid to get approval. Once Medicaid approves, other private insurances approve too. And then when you are using airway device, it comes in specific nasal cannula. These are called as OptiFlow nasal cannula. There are different sizes of the nasal cannula. So when you are giving the flow based on what cannula you are going to select. So cannula size that dictates the flow. So you have a cannula that is used for children, newborn babies. You have cannula for adults. You also have a cannula that can be used for tracheostomy patients. So you have a different interfaces, OptiFlow nasal cannulas that can be used for airway devices. So we talk about these are just a slide is an example of different air cannulas, and then what are the flows that are recommended to be used with each and every cannula. For example, if you look at this cannula there, so the maximum flow you can use only up to 20 liters per minute. If you look at this cannula, you can go all the way up to 60 liters per minute. So these are all the company specifications about the OptiFlow use. So it is important to know, in contrast to CPAP, which is totally leak proof, meaning you need to have a tight fitting of the nasal mask or full face mask without a leak. Whereas when you are using high flow, you need to have a leak. It is a partially open system. So the cannula fitting is an extremely crucial part. You have to select the size of the cannula, which is going to obstruct only 80% of the nares. You need to have a 20% gap in the cannula and the nasal cavity for the high flow nasal cannula to be successfully adopted there. So the biggest advantage of this is you can give 100% oxygen. That's why it is being used in intensive care units. Very rarely we use 100% oxygen for OSA patients, so this is not necessary for obstructive sleep apnea patients. So, and then there are some challenges in using the device. There are various cannulas. You have to select the right size cannula. There is a variable flow rate. So each patient may need more and more flow. This is not as simple as putting him on auto CPAP, putting him on 5 to 20, and then send him home. It is a very challenging aspect of the treatment. And then integration of oxygen, and then oxygen delivery is going to be continuously monitored. You have to titrate the oxygen, titrate the flow so that you are able to reach the target saturation of 93%. Humidification, the setup is very cumbersome setup. You need to have 1 liter water bag, you need to have a stand for the bag to be hang, and then you need to have the device. So it is not a portable device, it is more like a stationary device. So these are the challenges. DME denial. At this point of time, I mean, for a CPAP, you can download the equipment. You can see so many things in the download, right? What is the mean apnea hypopnea index? What is the usage? 50%, 60%. So you can assess the adherence over long term using the download. Whereas the airway device, they don't have a mechanism to download. It only tells you how many hours the patient has used the device. And then FDA approval is also a huge challenge there. So it is not that it is a simple device that can be prescribed to any patient with obstructive sleep apnea. So I'm going to conclude my talk telling you obstructive sleep apnea is a common disease in children. We see a very complex patients with obstructive sleep apnea, and then there is a significant number of children with complex medical diagnosis, and more importantly, obesity children who are already has tonsillectomy, no improvement, who are already using CPAP, not adherence, and then they are not candidates for any more surgery. They are looking for other alternative treatment. So high flow nasal cannula fits into that need. However, the studies what we have are very limited number of studies. That I have shown you, there's only 6 studies. Each study is only about 5 patients. So all over the world, you have maybe about 30, 40 patients who have used high flow nasal cannula. The advantage is you can use for any age group, you can use for different type of disorders. However, we need more and more research, more and more experience in using the device on a large scale so that it become an integral practice of treatment for OSA in children. With that, I conclude my talk, and I will be happy to take any other questions.
Thank you.
Sure.
Wonderful
Thank you.
presentation. That was really good. So we're a little bit short on time, so I think we're just going to do one question
Okay.
From the group, if that's okay. So for grade school age children with obesity, OSA phenotype,
Good.
is there a certain panel of labs that you would routinely check related to the systemic effects of sleep apnea?
Oh, that's an excellent question. So normally, if you are a physiologist and if you are an intellectual person, you would like to check CRP. That will give you proof that there is inflammation. But there is no medication that can treat inflammation. That is only confirm your suspicion. However, we always do a panel. You do the lipid panel, you do hemoglobin A1C. So those are the, those are the things that are routinely done in all patients with obesity. And then you have to also look at their blood pressure, making sure that they are not hypertensive. So all obese patients, you have to screen for hypertension, screen for hyperlipidemia, screen for glucose intolerance based on hemoglobin A1C level. And then if you see hyperlipidemia and then hemoglobin A1C level, you need to refer to endocrine. Some of them may be candidates for medication therapy. If the patients are having a higher blood pressure, what we do is we refer to the cardiology. They do 24-hour blood pressure monitoring. Some of them may be candidates for medication therapy for hypertension. All those things need to be incorporated into your clinical practice.
Very good. Thank you.
Thank
Sure.
you so much.
Thank you.